So good evening, everyone. Welcome to Africa Healthcare Network Fireside Chat Series 133. It is my pleasure to once again welcome Dr. Swapnil Hiremath. Dr. Swapnil Hiremath is a staff nephrologist at the Ottawa Hospital and an associate professor in the Faculty of Medicine at the University of Ottawa, and also an associate scientist in the Clinical Epidemiology program at the Ottawa Hospital Research Institute in Canada. His medical education has been at the University of Mumbai and at the University of Ottawa. He also has a master's in public health from the Harvard School of Public Health and a certification from the American Society of Hypertension as a specialist in hypertension. His primary research interest is in using systematic reviews, meta-analyses, and decision analytic modeling to improve care for patients with hypertension, chronic kidney disease, hemodialysis, and patients with acute kidney injury. He has authored more than 100 papers, and all these details are available on Google Scholar. He is also the co-founder of the open online Twitter, or now as they call it, X-based journal club, #NephJC. Be sure to check that out. And a faculty on the Nephrology Social Media Collective Internship, the NSMC. Dr. Swapnil has had two wonderful talks with us previously on radio contrast nephropathy and social media in nephrology. And tonight he's going to be talking to us on the approach of difficult to control hypertension. It is so lovely to have you back, Dr. Swapnil. Welcome.
Thank you. Thank you for that lovely introduction. And I'm really happy to be back as well. Yeah, so in terms of disclosures for today's talk, I don't have any financial conflicts of interest. I do have some research grant funding. And I am also on the Hypertension Canada Guidelines Task Force, but whatever I say today is my own personal opinion. It's not on behalf of the guidelines. And I said the objectives for today is to review the variability in the guidelines around this topic, but talk about some really basic stuff, right? Not just the new stuff. It's about to understand the importance of proper blood pressure measurement, understand the value of assessing non-adherence and simple drugs in these kind of patients. And if you want, this is sort of what I will be going through in the next hour, in case you just want to, get the highlights beforehand, is that hypertension control, though we are nephrologists, hypertension control really matters for kidney protection. More for cardiovascular protection rather than kidney protection. And proper blood pressure measurement is really the most important step. Non-adherence is common in chronic kidney diseases, such as especially in hypertension. And I think non-adherence is more common than secondary hypertension. And there are indirect measures. There are different ways you can measure, and that we'll go through. And when it comes to fourth drug, after the first three drugs, spironolactone is probably the most important one. As using SGLT2 inhibitors is a useful adjunct, and there are newer drugs and device therapy, though not yet approved everywhere. The benefit is really small, and cost is a consideration. So just to set the stage, hypertension prevalence is increasing. This is, of course, this is the global burden of disease data all across the world, showing how hypertension is increasing. And if you think it is because of the aging population, even if we look at age standardized rates from 2000 to 2015, they are definitely on the upswing. Unfortunately, blood pressure control is worsening. This is, of course, American data. The same is true even in Canada, and I'm sure it's true across the world. Even with COVID, it is even worse because attention was focused on the pandemic. Is that in the last few years, maybe even the last decade, the control is actually getting worse for various reasons. Now, of course, why do we treat high blood pressure? Is that high blood pressure is associated with a lot of badness. This is again from the global burden of disease, and all those colors, they are showing the different diseases, the red being the heart disease, and green being kidney disease, and the middle portion being stroke. But the nice thing about this graph is that if you see, the x-axis relates to the blood pressure. And if you see, there are very few people who have those extremes of blood pressure that you panic about, right? 180 or so. Most of the people who are having bad events are actually in the 120 to 160 range, or rather 140 to 160 range, which is, it's high. We know it is high, but it's really important to treat even those 140, 150 numbers and bring them down, because that's where most of the bad events are going to happen. And if we look at the benefit of lowering blood pressure, this is kind of the really nice way of putting it. This was the blood pressure trialist collaboration. So they got all the large trials and they pulled all that data together. So roughly 60 trials. And we can see here that lowering blood pressure can bring you down the risk of cardiovascular outcomes by about 20%. But in stroke in particular, heart failure and stroke come down by roughly 30% with decreased blood pressure. And even all-cause mortality by about 10%. Now, as nephrologist, the decrease in kidney failure is actually pretty small. It's, maybe 5%, and it's not statistically significant. It may matter more in those who have proteinuria, but otherwise, you treat blood pressure more to reduce heart disease and stroke rather than kidney disease. But it still matters to us as nephrologists. One, because our patients have, the resistant hypertension risk increases with as the GFR goes down. It also increases as the albuminuria goes up. So most of our patients have high blood pressure and they have difficult to control hypertension. It's not something you can treat with one drug. And most of our patients who have chronic kidney disease, they actually die of cardiovascular disease right before they go on dialysis. They don't die of kidney failure necessarily. Cardiovascular disease, even on dialysis, cardiovascular disease is a big thing. So that's something we should be really trying to reduce for the patients that we see in the clinic every day. Now, when it comes to guidelines, I'm from India originally, and this is a buffet, and we do have a guideline buffet here. There are many different guidelines with many different numbers. And this is just showing you the variety of numbers that are out there, ranging from the ACC, the Americans, who have 130/80 for everyone, and the European guidelines, which are, 140 for this, 120 for this, 130 for that. The KDIGO guidelines for the kidney disease improving global outcomes, they are saying go to 120 for almost everyone, unless you are a transplant patient. So that's, the other extreme that is there. And there are, all these other countries with other guidelines. But when it comes to resistant hypertension, there are, even in this, there are differences. So the American guidelines again say 130/80, whereas the European guidelines say 140/90. And when it comes to us in Canada, we sort of chose something in between. We are saying it depends on what is the target. So blood pressure above target. And why is this discrepancy? I think for the Americans, they are worried because their guidelines can become performance measures. So how much they get paid may depend on whether they reach those targets or not. That's why they said, hey, let's do 130/80. Whereas the European guidelines, the lower numbers, which KDIGO took 120/80, and they took 120/80 because they really went all with the sprint data, the sprint trial data. The Europeans don't like the sprint trial, which was done in the US. So they say, oh, we don't like it. Let's go to 140/90. And if you look at the European guidelines, they are very difficult to follow. I'm sort of saying this only half jokingly. They kind of say lower blood pressure to, if it's more than 140, and try to get it to 130. Or less than 130, but not less than 120. But if it's CKD, then you go for less than 140, not 130. If there is diabetes, you go to less than 130. And go and maybe go to this if it's a Tuesday or a Friday. It's kind of treating, and biology. When you give a pill to a patient, you cannot say whether their blood pressure is going down by 5 or 10. So it's hard to keep it in that 120 to 130 or 130 to 140 range that the European guidelines want you to do. They treat human being more like physics than biology. Whereas, the American guidelines are just simple, 130/80 for everyone if you want to buy that, or the KDIGO 120 for all of CKD. We, of course, chose this nuanced guideline saying it depends on the target. So for us in diabetes, it's 130/80. So we say more than that is resistant hypertension. If it's high cardiovascular risk, it's less than 120, and so on. But I want to pivot to something that I think is really important. It's about measurement, and measurement is the most important thing when it comes to treating hypertension. If you don't measure blood pressure properly, you're going to be in deep trouble. And as doctors, we are really, really bad at measuring blood pressure. So this was a study done by the American Medical Association, and they got medical students, and they said only 1 out of 159 students measured blood pressure properly, right? And luckily they got medical students. I'm sure if they would have got consultants, it would have been just as bad, and we would have looked pretty bad in this study. And they looked at these 11 skills, right? And you may say, oh, it's a rushed clinic that I'm having. I may not have time to do all these things properly. So let us see how important these things are. So this was a systematic review which looked at all the studies which measured the impact of measuring blood pressure improperly and how much of a difference it matters. So you can see here, if someone has had coffee, that can give you a blood pressure that is about 3 to 15 millimeters higher. If someone has had a smoke, it could be like 3 to 25 millimeters higher just before measuring the blood pressure. If your patient's bladder is full, you can get a blood pressure that is higher by about 4 to 33 millimeters of mercury. If it's a cold exposure, similar 5 to 32 millimeters. So these things really do matter. Similarly, it depends on the position. If the arm is not supported, it could be about 5 millimeters higher. If the arm is lower than the heart level, it could be 3 to 23 millimeters higher. Depending on the technique, right? Are you talking during the measurement? Is there excessive pressure? Do you deflate it very fast? There can have effects on blood pressure. So all these things are really important. Many of these things would mean, maybe 1, 2, maybe you will diagnose someone with hypertension when they really don't have it, if they come in with a full bladder. And this is, actual measurement, right? Is your hearing good enough? If it's a Korotkov method that you're using, are you rounding up, right? If it's 27, do you round it up to 30 or do you round it down to 25? So all these things can make a difference for you. So how do you deal with it, right? So you can divide these factors into patient factors, like, the coffee, smoking, full bladder thing. You can divide that into procedural factors, right? Are you deflating the cuff fast? Are you talking during the measurement? Are they resting properly? Or the position, is the back supported, and so on. And observer factors. And better education will help with everything, right? And we have been talking about better education for 3, 4, 5 decades, and still that doesn't happen. But these automated oscillometric blood pressure monitors, which are cheap, they are widely available now. They can take care of a bunch of factors. They can take care of the observer factors. They can take care of some of the procedural factors. Now, the machine, of course, doesn't know that whether the patient's bladder is full or they've had coffee. So, we still have to look at those factors. But many of these things, more than half of those errors can be eliminated by using automated oscillometric blood pressure measurements. For example, this study shows that if you just wait for 5 minutes more, before you measure the blood pressure, about 10% patients will have controlled blood pressure. And this was shown, this was a Canadian study from over a decade. This is a monitor that's no longer available, but again, they took 6 measurements. They discard the first and take the average of the next 5. And you can see the numbers come down from 147 to 133, right? And the average is 136. So an average of blood pressure, which is about 11 millimeters lower just by doing a proper blood pressure measurement. Which would often mean that your patient doesn't need as many pills as you're giving them. And this is similarly comparing with that arm-round machine that was used in Sprint, that the blood pressure was lower by about 12 millimeters of mercury. The important thing in this graph is to show that you cannot just take a blood pressure poorly and subtract 12 millimeters from them. So the spread is minus 46 to plus 20. So when you take a blood pressure poorly, the actual blood pressure the patient has, the resting blood pressure, may be anywhere from minus 46 to plus 20. So it's really important to measure the blood pressure properly if it is possible. And we did this locally as well, and we found a similar difference, about 7 and not 12. But it all varies, right? So it's important to measure it properly. And we also looked at whether someone was there in the room or not while the blood pressure was being measured, and it doesn't really matter. So even if you have like a waiting room where you can set up a kiosk with some blood pressure going on before you actually see the patient in your clinic room, that would be fine, because again, this takes 10 minutes, right? Your overall appointment time may be 10 minutes. So to have 10 minutes spent in measurement may not be practical, but you could do it before you actually see the patient. And why does it matter, right? If you look at the trials, so we say that you should be treating blood pressure to 120 or 130 on the basis of data from these clinical trials. Now, how did these clinical trials measure blood pressure? Well, all of them, even the older trials, though they were manual, they had this 5-minute rest, and they did an average of 2 or 3. So, if you are extrapolating the data from the trials to treat the patient in front of you, it behooves us that we should check blood pressure the same way it was done in the trials, right? And the manual method and all was so painful. With these machines, it makes the whole job so easy. It kind of automates, it takes away the human error aspects. So it really makes a lot of sense to do it that way. And the guidelines also sort of say that, right? Even the International Society of Hypertension guidelines, though they don't like unattended, which is fine, they do say, take 3 readings, try to use a validated oscillometric or a calibrated oscillatory method, and take 3 readings and average the last 2. So that is sort of where every guideline is moving towards. And if standardized blood pressure, KDIGO calls the automated oscillometric as standardized blood pressure. The standardized blood pressure must be used for making treatment decisions, and it may be higher than the casual blood. It will be lower than the casual blood pressure, but the limits of agreement is pretty large. And you have to work out the logistics, right? You have a separate room, you have to do it in the waiting room, or you can do it in the same room while you're looking at the next patient or documenting something. But it's really important to measure it properly if you're treating it. What about out of office? I keep talking about office blood pressure. What about out of office? So there is ambulatory blood pressure monitoring if it is available. It is not widely available across the globe. Even in Ontario, the state where I work in, it's not reimbursed, so we have difficulty getting it. But if it's possible, out of office gives you a way more. It gives you assessment of blood pressure outside the clinic, overall blood pressure load, the pattern, especially the nocturnal dipping pattern, or certain activities precipitating it. And you can divide patients into, white coat hypertension. So those patients whose blood pressure is high in the clinic or in the office, but it's normal out of the office at home. You obviously wouldn't treat those patients. But the other important aspect here is masked hypertension. So there are a lot of patients whose blood pressure is higher outside the office, and they are relaxed when they come and see you. It seems paradoxical, but there are some people like that. And this is very common in diabetes, and even more so in CKD. In CKD, this prevalence may be even higher than 30%, maybe 40%, and these patients have bad outcomes. So you're not treating their blood pressure as much as you should. And there is still trials going on in this area, but it's important to recognize this masked hypertension phenotype. You may say, hey, why ambulatory, right? You can do home blood pressure, and home blood pressures are perfectly fine. They are probably a very good surrogate for doing ambulatory blood pressure monitoring. Just important is that all home blood pressure monitors may not be accurate. People may be buying monitors from online or wherever. They may be manufactured who knows where, and may not be necessarily be calibrated. This was a study we did in Canada showing that about 10% of the monitors were off by about 10 millimeters of mercury, which again would make impact and decision making. And there are these listing, right? This is the American Medical Association listing called validatebp.org. Which is useful. The International Society of Hypertension has got this tridebp.org, where you can go, you can check if this monitor that patient is buying is validated or not. These are very, they're user-friendly websites, free to access. We have our own in Hypertension Canada that you can use if you want to look at which devices are accurate and validated. So now let's go back to the treatment of hypertension, right? So this is sort of an algorithm that we came in, that if you have a patient whose blood pressure is not controlled despite 3 drugs, you should rule out white coat effect, either with ambulatory or home blood pressure monitoring, and then you optimize the therapy. So what do I mean by optimizing the therapy? The standard first line drugs for most patients should be ACD. So that's a calcium channel blocker, one of the dipines, dihydropyridine calcium channel blocker, an ACE inhibitor or an ARB, and a diuretic. My preference until recently has been using either chlorthalidone or indapamide. So thiazide like diuretic, not hydrochlorothiazide. But this trial was published recently called the diuretic comparison project. It compared chlorthalidone to hydrochlorothiazide for preventing cardiovascular outcomes. And as you can see, there was absolutely no difference in benefit. So chlorthalidone was not superior to hydrochlorothiazide, but in fact, it caused more hypokalemia. So there were more adverse events. Now, my take is that if the blood pressure is controlled, there is no reason to switch from hydrochlorothiazide to chlorthalidone. If the blood pressure is not controlled and someone's on 25 milligrams of hydrochlorothiazide, you could either increase them to 50 milligrams, or if you switch them to 25 of chlorthalidone, that's more potent. So it's equal to 50 of hydrochlorothiazide. But I think hydrochlorothiazide is fine to use. It's just that we don't use high enough doses. In chronic kidney disease, even if the GFR is less than 30, thiazides do work, but you will probably need higher doses like 50 of hydrochlorothiazide or 25 of chlorthalidone for it to work. So then what do you do, right? You have them on ACD, then you add, you make sure everything is ideal, but their blood pressure is still high. Then, there are a few things you can do. You can assess for secondary hypertension. And you can think about adding a fourth agent. So what fourth agent should you be adding? So we are mostly informed here by the Pathway 2 trial. This was a large trial done out of the UK where they took patients who were on ACD, ACE inhibitor, ARB, calcium channel blocker, and diuretics, and his blood pressure was still high on the basis of home blood pressure monitoring, and they randomized them to getting placebo versus spironolactone, doxazosin, which is an alpha blocker, and bisoprolol, that's the beta blocker. And spironolactone was the most effective. So it reduced blood pressure by about 10 millimeters compared to placebo. And doxazosin plus bisoprolol were about 5 millimeters versus placebo. So the most potent was spironolactone, which is hence now the fourth drug that you should be adding. And this is kind of interesting, is that they measured renin level, and they show here that spironolactone was really effective, right? They got 30 millimeters lower blood pressure in someone whose renin was low. And at the other end, if the renin was high, all these drugs were equal. Bisoprolol doxazosin and spironolactone were similar, but especially in the patients with low renin. And what happens is, who are the patients who have low renin? They are the patients who have primary aldosteronism. So these patients are really mostly undiagnosed primary aldosteronism. And it's not just in this trial. All across the world, screening for primary aldosteronism is very low. This was a large American trial, a study done out of the Veterans Affairs, showing that a very small number of patients, they started off with over 1 million patients, and only about 35,000 patients, only about 4,000 patients were tested for primary aldosteronism, and out of them, very few actually got spironolactone. So we are very bad, and even in resistant hypertension, it's very the dark green at the top is the number of patients who are screened, and you can see over time things haven't improved, right? Despite all the education, despite everything we are talking about, we don't screen for resistant hypertension. And the important thing for primary aldosteronism, the important thing to keep in mind here is that hypokalemia is seen only in a minority of patients with primary aldosteronism. So you should not depend on its presence for screening. If anyone has difficult to control hypertension, 3 medications, screen for primary aldosteronism. They need not have hypokalemia or other factors. You don't need to look for an adrenal nodule. Just screen them. And the basic principle is that, the primary aldosteronism, yes, you get hypokalemia and hypertension, but because the aldosterone is high, because of negative feedback, the renin is low. So what you get is you will get a high aldosterone and a low renin in these patients. And that's all you need, really. And you can check for a renin if you don't want to check for an aldosterone. There are all these ratios which make it hard for people. So just do that. Check renin. If it is low, think of primary aldosteronism. The only drug that matters is the MR antagonist, spironolactone and eplerenone. So hold them. And 24-hour urine is a valuable test. If once you have a patient who looks like they have a PA or you're suspicious, then you can also do 24-hour urine test. And if they have that, just give them spironolactone. Some key management tips are that spironolactone has adverse effects, especially anti-androgenic adverse effects, gynecomastia, dysfunctional uterine bleeding, decreased libido. And often in patients with PA, you need 100 milligrams or more. So you're more likely to get those side effects. So eplerenone can be used. It's only half as potent and short acting. So 50 milligram of spironolactone is equivalent to 50 BID of eplerenone. If you can't get that, then amiloride or triamterene might be acceptable. They don't block the aldosterone everywhere, but they do have effects on the channel there. There are some new drugs which are coming in which actually inhibit aldosterone synthesis. There are phase 2 trials that have been completed. So there's a lot of research going on in this field. I think we are going to see more science in the next few years. So this is, I'm just taking a break here to show you how this is Ottawa in the winter. It's very black and white, but it's a very beautiful country. If you ever come across here, let me know. This is the Parliament Hill from the other side in our capital. So what if you have done spironolactone and you're still struggling? You can use alpha and beta blockers. And again, from the same pathway 2 trial, they do lower blood pressure by about 5 millimeters more than placebo. So less than spironolactone, but more than placebo. So they are options. I know alpha blockers are very, very commonly used. I know when I practiced in India, they were used way more than other drugs. They have a very nice metabolic profile. They don't increase the creatinine. They don't cause gout. They don't cause hypokalemia. On the other hand, they do increase the risk of heart failure. And in elderly patients, we looked at this. They cause that sudden drop in blood pressure, which can cause falls, fracture, syncope, right? So most of our patients are at risk of these things. So use them only if you have to use them. Don't use them just because they're easy and convenient to use. And always be a flozinator, right? SGLT2 inhibitors. So why am I bringing in a diabetes drug on a blood pressure talk? Well, they do reduce blood pressure by about 4 to 7 millimeters of mercury, depending on how much of sodium retention and glycemia is there. And this was a study looking at this post hoc from the EMPA-REG. And again, they showed that the blood pressure was lower with empagliflozin compared to placebo. And the outcomes were lower, right? Across the board, depending on all subgroups, empagliflozin was able to reduce cardiovascular death, hospitalization for heart failures, even in the population who had apparent treatment-resistant population. So, it not only did it reduce BP, it reduced MACE. Now, I'm not saying that you go ahead and use it in patients who have resistant hypertension, But most patients who have resistant hypertension will have some indication to use a Flozin, right? So let it be, for example, they may have chronic kidney disease and proteinuria, so you should be using a Flozin. They may have diabetes, so you should be using a Flozin. They may have heart failure with preserved ejection fraction, so you should be using a Flozin. So most of the patients who have resistant hypertension will have some other indication to use a Flozin. So use that as a reason, and you will get the blood pressure down and probably have some other benefits, reduce the risk of heart failure and kidney failure as well. Endothelin antagonists are coming in the play as well. Endothelins are have a variety of effects on the kidneys as well as vasculature. And there is something called aprocitentan, which is a dual endothelin antagonist. And this was a large trial published last year, which showed that as compared to placebo, it reduces blood pressure by about 5 millimeters. Excellent trial design. This was a fantastic, well done trial. Took care of a lot of things I've been talking about. But note these, that it does cause adverse effects, right? So it will cause fluid retention and heart failure. So you have to be careful when you use these drugs, especially in the CKD setting. Not yet approved, but it's likely to get approved in the next few months. What about device therapy, right? Something new, exciting, so renal denervation. There are many systems. There is the Medtronic has the spiral system. Recor has this ultrasound system. So there are many different ways of doing renal denervation. But if you look at the studies, really, it's less. It's quite underwhelming. So the initial trials about a decade ago showed that the blood pressure may drop by 30 millimeters of mercury. Right, you're going to cure hypertension. But then the Simplicity 3 study, which was the best study done so far at that time, it showed that really compared to placebo, if there was really no benefit. Since then, some better trials have been done. They show that the difference is about 4 to 5 millimeters of mercury after controlling for placebo. So they do lower blood pressure, but it's not 30 millimeters. It's about 4-5 millimeters. Now, the last trial that came out actually shows that compared to placebo, compared to the sham, there was not enough of a difference in blood pressure. That is because the control group got more blood pressure pills. So, what should you be doing? To be honest, I'm not sure how excited you should be about renal denervation. The benefit you get is like adding one drug. And it's likely to be very expensive. I don't know if it's widely available in your part of the world. In Canada, it's going to be available soon in the next few months. But we are worried about the cost. It's going to be many thousands of dollars. And most blood pressure pills cost, a few cents. So a few pennies versus so many thousands of dollars for a small difference, I'm not so sure. It's probably only in a select few population that it will be useful. So in the last part of the talk, I actually wanted to pivot to something that is less exciting compared to renal denervation, but I think is way more important. And that is adherence. Previously we used to call it compliance. Now we call it adherence. In the future, I think we'll be calling it concordance. So the patient and you are concordant with the therapy. This is a huge issue, and this has been a huge issue forever. So even Hippocrates had said that you have to keep a watch on patients who don't tell you, who lie about the things they're supposed to take. And because they don't take these things at that time, they are mostly purgatives. They sometimes will die. And this was a past US Surgeon General, Dr. Koop, who said, drugs do not work in patients who do not take them. This is kind of the old-fashioned paternalistic, way of saying, but it's true that, if your patient is not taking the drugs, then they are not going to have the benefit. So what do we do about it? This is a really nice graph to think about adherence. And the blue line is telling you how many patients are taking blood pressure drugs over time. If the line is at 100, then there's perfect adherence. They are taking blood pressure. But you see what happens is right in the beginning that about 5% of patients, their adherence drops. Why does that happen? So this is in Europe. This was a study done in Europe, in the UK actually, and it showed that despite having coverage in the UK, 5% of patients, take the prescription and they throw it in the garbage. They don't go and fill the prescription. And there may be various reasons for that, right? Maybe they don't understand why this high blood pressure number should be treated. Or it may be that, drugs are expensive. They don't have money to go and buy those drugs. Maybe they don't have insurance. Who knows what? So about 5% of patients will not fill the prescription right in the beginning. And then over a period of time, you will have this drop off. Now, why does this happen? This may be many things, right? It may be that they have side effects. And rather than come back to you and tell you that they're having side effects, they just stop taking the drug. The other thing may be that they don't see any benefit, right? If you're taking a painkiller, and you take you take acetaminophen or paracetamol or ibuprofen and your joint doesn't hurt, the drug is working and you're going to keep taking it. In hypertension, it's an asymptomatic condition. So you take this pill, you're supposed to take this pill, maybe you have some side effect, and it doesn't do you any benefit unless you measure your blood pressure and see it come down. You may think, yeah, I mean, the doctor said to take it. I don't feel like taking it, and they stop. So there are many reasons like that why people will stop in the first few months. And then the difference between the blue line and the red line is the difference on a particular day, right? So a patient is taking the drugs, but on a particular day you forget to take them. So that's about 10% of patients. So about 10% of patients will forget to take the drug on any particular day. So for that kind of a problem with adherence, you will, you need a reminder, or, you put pills in a box with all labeled at what time you should take them. So those kind of interventions will be helpful for that kind of non-adherence. But at 1 year, roughly half the patients for chronic cardiovascular conditions, including hypertension, they have stopped taking their pills, right? So think of the patient you have been seeing in your outpatient clinic, and about half of them have stopped taking the pills that you prescribed to them a year ago. This is not uncommon at all. And doctors overestimate adherence, right? They think, oh yeah, my patient is taking pills. Many of your patients are not taking their pills. So how do you diagnose it, right? So I would like to think about this as subjective and objective. Subjective is that, the patient will tell you. You ask the patient, they'll tell you. Or it's your assessment of how many they are taking. And I would say the best way to do this is not to be judgmental, right? Don't say, oh, you are not taking the pills. A non-judgmental discussion. And Josh Flynn, who's a pediatric nephrologist in Seattle, kind of said, this is the way he does it. And he deals with children, teenagers, right, who do what they want. Is that rather than saying, have you forgotten to take your pills? You kind of normalize it and you say, how often do you miss taking your pills? Saying that it's acceptable to miss taking your pills, just how often do you miss it? And then you're more likely to find the truth. But then there are objective assessments. So there are, you can do electronic monitoring, you can count the pills in their bottle, you can check the pharmacy, how often they're filling. But this is an extreme story. So this is the real patient we had. This is a 53-year-old woman who was referred to us saying, hey, do that renal denervation thing. She was overweight. She did have sleep apnea. Her resting blood pressure was about 200 over 100, and she was on all these medications, angiotensin receptor blocker, beta blocker, alpha blocker, diuretic, mineralocorticoid antagonist, another diuretic. And we had a research study going on, so she did undergo denervation, but the blood pressure remained high. And then clonidine was added, right? So you look at the numbers, right? They are very, very high. We did an ambulatory blood pressure monitoring. It was high, and it remained high. The interesting thing was that, even when she stood up, the blood pressure didn't fall despite being on alpha blocker, beta blocker, clonidine. So that made us think, hey, what is going on here? The pharmacy records were perfect. She said she's taking her pills. So then we did something else, right? So there are two ways of doing direct assessment of objectively. You can do direct observed therapy, or you can actually measure the drugs in the urine. So direct observed therapy, as most of you know, it's well accepted for TB, right? To ensure ongoing adherence. In this case, we are saying not for treatment, but for diagnosis. And can it improve the level of control? So this is what happened when we brought the patient in and gave her all her blood pressure pills. Her blood pressure dropped to 97 from 177. So she was just not taking her pills, right? She didn't need any fancy denervation. She just needed to take her pills. There was a little bit of a panic in the clinic that day, but we kept her for a few hours. And after about 6 hours, the blood pressure did come up to about 140. And then we let her go home. And this is a systematic review that I did that's been published a few months ago, showing that, if we check the indirect methods, we think that non-adherence is about 18%. But if you do direct measurements, it's actually about 45% patients who are non-adherent to medications. And in resistant hypertension, indirect methods can underestimate non-adherence by about a 3-fold magnitude. So it's really important to look for adherence properly. And we did a prospective study. This was the sort of protocol where the patients come in at 8 a.m. We confirm with them that they haven't taken their pills for that morning. We check the blood pressure with the automated machine, and then from our pharmacy, we get their drugs that they're supposed to take, and the nurse watches them swallow the blood pressure drugs. And we check blood pressure every half an hour until it plateaus. And then we put a ABPM afterwards. And what we saw that just with DOT, the blood pressure dropped by about 10 millimeters. We checked them a month later, and their blood pressure was still, in a graphical form, this is how it was. Their blood pressure was still lower even without DOTs. So something woke up. About a third of the patients were now controlled just by doing direct observed therapy. So it's a useful way, I think, of checking for non-adherence. Other trials have shown that in this case, this was a resistant hypertension population. A very small minority of patients were adherent. Most of the patients were non-adherent. About 40 out of 76 were non-adherent to the blood pressure drugs. Even in the trials, they did measure, and they found that the red is the proportion of patients at baseline, 3 months, 6 months in the renal denervation trials who are non-adherent. So it's very, very common once you start looking for it. And you can do that therapeutic drug monitoring. I don't have it available. It's very expensive for me. But in the US and in the UK, they have this available. It may be available in other parts of the world, where you can check the urine to see which drug they have in the system. Whereas direct observed therapy, to me, it's very cheap. All you need is a room and a nurse to check the blood pressure, but it does take time, right? The 4 hours that they have to be in a room to get the blood pressure checked again and again, and safety sometimes is a concern. But so these are, I think direct observed therapy, we really like it. We use it here a lot. That's our way of checking for adherence, and then we can focus our efforts on adherence rather than do a renal Doppler or angiogram or pheochromocytoma workup or what have you. And this is white coat adherence that is described, is that after you see the patient, they take the pills for the first few days, and then slowly over a period of time, adherence decreases, and before the visit, adherence increases, right? So it's an ongoing challenge, right? When the patient is not being seen by you, they forget the doctor, they forget their high blood pressure, they stop taking their pills. And only when the appointment comes up, they say, oh yeah, I forgot to take my kidney pills, I have to start taking them. And it is complicated, right? So this is a really nice study. In patient 1 was perfectly adherent. Patient 2, as you can see, was perfectly adherent until they stopped taking their pills suddenly. Patient 3 was, scattershot. Sometimes they would take the pills in the morning, sometimes they would take it in the evening. The arrow marks are, the days that they forgot to take the pills, and at 6 months they stopped taking it. And patient 4 is somebody who was, missing. Sometimes the timing is off, but they have remained continuous on their regimen. So adherence is a complicated diagnosis. There are many different reasons for it. There are many different ways it can present. There are many different ways of diagnosing it. It's kind of, basic clinical medicine kind of skills that you have to apply here. But I think it's really important to do that, because otherwise you're just adding pills or doing workup when your patient is just, non-adherent to those pills. These are some really good papers. This is free to read. Lisa Rosenbaum has written a nice essay in the New England Journal of Medicine. There is Carolyn Thomas has a Heart Sisters blog. And she describes it from a patient perspective, saying, it's easy for the doctors to say, take your pills, take your pills. But every day the patient, looks at the pills, it reminds them that they are a patient, right? She talks about having a blood pressure pill, the aspirin, the clopidogrel, the ACE inhibitor, the beta blocker, the cholesterol pill, the statin. And she's like, all these pills that I'm taking, they remind me I'm not a normal human being anymore. I hate taking my pills. And that's the kind of thing that you have to work around, right? The patient live their life with the disease. We don't. It's easy for us to do this, do that, but try to work with them to make sure the adherence is treated. There is a really nice podcast that we recorded with Carolyn and with others. It's you can Google for unmet needs in hypertension, and you can get access to. It's freely available. There are many podcasts. We talk about renal denervation. We talk about lifestyle. I didn't touch about salt and potassium and all that here. There are a series of 6 podcasts that are free to listen and download. And some webinars as well. So Google American Heart Association unmet needs in hypertension, and you will see all that series. So to summarize, so that we have some time to ask, to have discussions, and I can see there are some questions in the audience. So hypertension control matters more for cardiovascular disease and less for kidney protection. But we should still reduce blood pressure, because kidney patients are mostly dying of cardiovascular disease and not of kidney failure. Proper blood pressure measurement, and I would say, using automated oscillometric methods, if it's available for you, that is the first and the most important step. Non-adherence is very common in chronic diseases such as hypertension, right? And in difficult to control hypertension, in resistant hypertension, the prevalence of non-adherence is way more than the prevalence of secondary hypertension. And indirect measures, if you check the pill counts, you ask the patient, they underestimate the true prevalence of non-adherence. If it's possible, do something like direct observed therapy in selected patients. Primary aldosteronism is the most common cause of secondary hypertension. So non-adherence, primary aldosteronism, right? Think about those two things. Check a renin level or give them spironolactone, right? So spironolactone is the preferred fourth drug to be added in patients with resistant hypertension. Some people argue that spironolactone should not be the fourth drug. Maybe it should be the third or second drug even, and that may be right. Especially in patients who have evidence of salt retention. But we lack data on end organ benefit, of course. SGLT2 inhibitors or flozins are another options, and often you will have a correct indication in these patients, whether it be diabetes, proteinuria, or heart failure. There are newer drugs on the horizon, aldosterone synthase inhibitors, endothelin antagonists, and others. They are looking pretty interesting. After a long time, we are having new drugs in hypertension, which is exciting. And there is device therapy, but the benefit to me, it's small. You have to look at cost and coverage, and discuss with the patients before going down that road. I like to thank these bodies and my mentors who have helped me go where I am with the science. And if you don't, this is my email in case anyone wants to ask me questions by email. My Twitter handle or X handle and Mastodon handle. We have a website called nefjc.com if you don't already use it, where we discuss nephrology articles. There is a podcast that we have called Freely Filtered, and always be a flozinator, right? Every day you see a patient in the clinic, think is our SGLT2 inhibitors ideal for that patient? So I'll leave up the summary, and I think we can go with the question and answers.
So thank you very much, Dr. Swapnil. This was such an engaging talk, and I think we probably hit our record number of attendees during this talk as well. So that's great. The item that has stood out the most is again on the talk on the flozinators in the management of hypertension, and I'd like to welcome Dr. Lloyd because he had a very interesting question. There's a question about the flozin on the chat box as well. So Dr. Lloyd, could we start with you?
No, thank you very much, Swapnil, for the wonderful session. It's a great idea because now flozins are now quite available, and generics are also coming out and used in diabetes, CKD, heart failure, and I think it's a great idea. So the question I had is, could flozins actually augment the effect of other drugs in use as well?
Exactly right. I do think that they do augment. Again, from a kidney point of view, I think these drugs are diuretics. They're natriuretics, and they probably are natriuretics with a very beneficial metabolic profile, right? So they don't cause hyperglycemia. In fact, they reduce blood sugar. They don't cause hyperkalemia. In fact, they reduce the risk of hyperkalemia. They don't cause gout. They reduce the uric acid. So they are natriuretics with a lot of benefits. So adding them when your patient is already on a thiazide and a mineralocorticoid antagonist, it's very useful. In fact, the risk of hyperkalemia with ACE inhibitors is lower if you're on a flozin compared to being on the placebo. So in many ways, they potentiate the natriuresis and they ameliorate the side effects that you see with other drugs. So whenever you get an opportunity, please consider using flozins.
Thank you so much. Thank you very much.
And thank you very much. Another question on the flozin again is that can this drug help those who are on maintenance hemodialysis? This is from the Q&A chat box.
Yeah, that's an excellent question, right? I would love to see that benefit. So I have used it off-label in a couple of patients who had bad diabetes, but who also had they have residual kidney function, so they were still making urine. So in those patients, it did reduce blood sugar. It actually caused a lot of natriuresis, and their weight gains were lower in between two dialysis. This was completely off-label. Now, if a patient has no urine output, if they are anuric, will these drugs still work? I don't know. Maybe then are there non-kidney benefits that these patients will have? So there is a really large trial called Renal Life Cycles. It's run out of Amsterdam with about 1,500 patients. They are also including patients on transplant, those who have advanced CKD, so GFR less than 20, and those who are on dialysis, including peritoneal and hemodialysis. And the recruitment is going well. So I think we will have some data on flozins and dialysis in about 3 or 4 years.
Another question is, any preferred approach to patients with an isolated systolic hypertension, and what would your choice of drug be?
Yeah. So that's, and isolated systolic hypertension is very common, right? In our patients, it's very common when there is chronic kidney disease It's very common when you have elderly patients because of the arterial stiffness. Really, diuretics are supposed to be better in isolated systolic hypertension. Calcium channel blockers are also not quite bad. This is, I'm talking from the SHEP trial where these drugs were used. This is again the drugs that we use anyways commonly, right? The other important thing with isolated systolic hypertension to keep in mind is that often the diastolic pressure will be low. And the jury is still out there. What do you do, right? If the blood from the SPRINT trial, in the lowest diastolic quadrant, that blood pressure, the diastolic was about 60, and going lower still had a benefit. But I kind of get nervous when the blood pressure is 55, 50, which does happen with some of our patients, and their diastole is when they get their coronary perfusion. So you have to be kind of careful. Beyond the drug use, you have to be careful if they have angina or something as to what is happening there.
Excellent. Thank you so much. And there's another interesting question here, and asking for your experience with minoxidil. I do use it for a couple of my patients here, but what would your experience be? And I assume that you would use it with a beta blocker too, right?
Yeah, exactly right. Yeah.
Would you share your experience with minoxidil? How often do you use it?
Yeah, so minoxidil is a little bit tricky. Minoxidil is very potent. It lowers blood pressure. And to be honest, after the approaches that I have talked about, right, once you rule out primary aldosteronism, once you rule out adherence, in non-dialysis settings, the use of minoxidil, the requirement for minoxidil is low. I do have a few dialysis patients where we have done everything and we still struggle, and that we use minoxidil. But the key thing with minoxidil is volume control. So patients can really, it's a vasodilator. Most vasodilators will cause sodium retention. That's something that you see. So that is the key aspect. So you need to use a lot of diuretics. If it's a non-dialysis patient, make sure they're on a lot of diuretics and they are as dry as they can be before you add minoxidil, right? If you've got someone who's volume overloaded, that's the cause of that hypertension, and it's not minoxidil. Minoxidil will actually make things worse. You may get pericardial effusion. And in a dialysis patient, the same thing applies. Make sure you have dried them out before you use minoxidil. So that's the only nugget I would add with minoxidil usage. It's a potent blood pressure lowering drug. You will get low numbers, but the concern is that are you going to cause harm? So make sure they are dry as can be.
That's great. Thank you so much. And Prof. Bhima has a question. He's a senior pediatric consultant nephrologist from KwaZulu-Natal in South Africa. Prof. Bhima, please, welcome.
Thank you very much, Amar. Dr. Swapnil, thank you so much for that very enlightening talk. This is one of my favorite topics. But I just want to ask a question about the use of aldosterone. You said it was a fourth agent. Now, the problem we, of course, have is that when patients have ACE inhibitors and they are getting aldosterone added to that, potassium is a big problem, especially the low GFRs. And I add it on and then say, okay, we can tolerate a little higher level of potassium if we're using a potassium binder. But my co-consultant will come and stop the drug to say, well, the potassium is going up. So with the use of spironolactone, what level of potassium would you tolerate, and how much more can you push up the diuretic, which means the hydrochlorothiazide? Because I thought the maximum dose was about 25 milligrams. You got any thoughts on that?
Yeah, that's an excellent question. So we don't use dual RAS blockade anymore, like ACE and ARB. But adding ACE ARB to spironolactone is dual RAS blockade anyways, right? So we pretend that it's fine, and we do use it, and the risk of hyperkalemia is higher, for sure. I completely agree with you that it is higher. There are a few strategies. One is that, of course, SGLT2 inhibitors reduce the risk of hyperkalemia. I don't know how commonly they are used in the pediatric populations. So that's one strategy.
There's no trials at the moment. So
exactly. It will be completely off-label to use SGLT2 inhibitors in pediatric population. Apart from potassium resins, you're right. The diuretics are the major thing. So hydrochlorothiazide, chlorthalidone, indapamide. So in adult populations, you can go up to 100 milligrams when it comes to hydrochlorothiazide, or 50 for chlorthalidone pretty easily. In pediatric populations, I'm sure that's not true. So I'll defer to you about those drugs. The concern, of course, is that once you get hyperkalemia and then you diurese them to get rid of the potassium, and the creatinine goes up, right? So that's the reason your colleagues are stopping, because they panic at that rise in creatinine. I think the rise in creatinine is acceptable. It's hypercreatininemia, right? It's not AKI. It's just hemodynamics. They are not getting kidney injury. So we should take a deep breath and accept that higher creatinine because you're getting a lower blood pressure. And I think the end organ benefit is what you're getting, despite having more drugs and a higher creatinine. So if it is possible, you have to be brave and persist if you can with the thiazide, with the whatever you can do, whether it's potassium resin or what have you, to keep things under control. And you keep your eyes on the end organ benefit is what matters. But unfortunately, what your experience you're describing is very common here as well, right? So it's very common to see spironolactone get stopped, ACE inhibitor gets stopped, they get put on hydralazine or terazosin or something, which are really bad drugs. They are not great drugs. They don't have any end organ benefits, but that's what often happens even in my practice.
Yeah, the biggest problem is people see a slight rise in creatinine and they say, well, we're making the renal function worse. You know what I mean? So stop the ACE, stop the spironolactone. But what they are seeing is what exactly you described. It's a biochemical effect, but it's no protective effect on the end organ damage. So I always say that if you, this is my take on it. If you see up to a 20% rise in your creatinine, just tolerate it. You know what I mean? Because the benefit of using the ACE and the spironolactone is much greater than the benefit of not using it. Because that's what long-term trials have shown in the adult population, not pediatrics. Right?
Absolutely.
Thank you very much.
Thank you so much. Thank you so much, Professor Bhima, for your question. I might get into a lot of trouble for calling Elliot out, but Elliot, you private messaged me your question instead of putting it on the chat box. So Elliot, can you ask your question live, please?
No, don't worry, you're not getting into trouble. Thanks, for the wonderful presentation as always. So I think it was just a follow-up when you discussed the isolated systolic hypertension. So it was a quick one. How about isolated diastolic hypertension? What option should we go for? Elliot here.
Yeah. And again, we don't have good trials to show that certain drugs will be useful in certain kind of hypertension. So the patient population who has isolated diastolic hypertension is typically middle-aged. So in the really young and really old, you have isolated systolic hypertension. That's just the pathophysiology. And in the patient who's 30, 40 years of age, you're going to have diastolic hypertension. But again, I think the same kind of drugs work. So there is no, I haven't seen anything very impressive to suggest that this agent is more effective in isolated diastolic and has a greater effect on end organ benefits. So I would say we should go towards the fact that what you're looking at is end organ benefit, and the three drugs that are most useful are RAS blockade, thiazide diuretics, and calcium channel blockers, followed by spironolactone. So I would still stick to that kind of algorithm, even if you have isolated diastolic hypertension.
All right, thanks.
And on the note of spironolactone, again, there's a question in the Q&A chat box concerning patients with CKD and resistant hypertension and a concern for hyperkalemia. Could you address that, Dr. Hiremath?
Yeah. So it is, and in fact, in CKD, it was thought that spironolactone is not effective. I didn't show this here, but we have a local study where we use spironolactone in those with CKD with GFR of less than 45, and we did see that spironolactone is effective. It does cause more hyperkalemia, of course, needless to say, but it's not as high as you would think. One is because many of these patients have, some element of primary aldosteronism. It may be a full-blown thing or subclinical. So that potassium is okay if this is working. But yes, you have to back off, right? If you are getting hyperkalemia, I'm not saying push spironolactone even if the potassium is 6. So do as much as is possible. If it comes that, because you're using spironolactone, now we have to add a potassium binding resin, then you have to think about, are you adding cost? And maybe it's time to bail and go to one of the non-preferred drugs like alpha or beta blocker. But the risk is high, but it is not as high as you would think. And if you maximize their thiazide diuretic, then you can sort of minimize that risk by doing that.
Concerning renal artery stenosis in relation to resistant hypertension and its treatment.
Yeah, so I didn't cover renal artery stenosis. Renal artery stenosis is probably second or third after primary aldosteronism when it comes to which is the common cause. There are a few causes of renal artery stenosis. So in atherosclerotic renal artery stenosis, as you know, the trials did not show that they improve outcomes. because previously 40 years ago we didn't have ACE inhibitors or ARBs. So yes, you had to do angioplasty or a surgical bypass. Now we have very effective drugs like ACE inhibitors on ARBs. So you don't, if there is unilateral renal stenosis, you don't need to give them an ACE or ARB, atherosclerotic. Sorry, you don't need to do an revascularization. You just give them an ACE or ARB, BP is controlled. The question is, if there is bilateral renal artery stenosis and they are having heart failure, pulmonary edema, then sure, you should do a angioplasty. The other big causes of secondary of renovascular hypertension is there is fibromuscular dysplasia, most commonly seen in women, in the young to middle-aged women. Those patients, there are no trials, but these patients do deserve angioplasty. For fibromuscular dysplasia, I will say it's also seen outside the renal bed. It's not just happens in the kidney. Many patients with fibromuscular dysplasia will also have carotid and vertebral aneurysms or dissections. So it's important to look at those places. And lastly, there is, Takayasu's arteritis or aortoarteritis. I know when I trained in India, it was pretty common to have what is called as middle aortic syndrome or aortoarteritis. I'm not sure how common it is in East Africa as well, but that is something that can cause renovascular hypertension, and often that has to be treated maybe with angioplasty, but some of these patients also require a surgical bypass. So it's a complicated topic, and if you have the patient who's clinically looking like that, yes, please go ahead and test and investigate for that.
Thank you very much. And a very common practice here again is the use of sublingual nifedipine to lower BP when it's especially high. This is again from the Q&A chat box. What would your thoughts be on that?
That's an excellent question. I remember in medical school, when I was in med school, I was an intern. We had done that, right? And it's a terrible practice. We should not be doing that anymore. It causes a huge drop. Sublingual depin is very effective. It bypasses the first pass and it gets absorbed, and it causes a big drop in blood pressure. So you will fix the number, which is why it's very popular. But actually, trials show that using that causes a sudden drop in perfusion, and it causes bad outcomes, right? A stroke, heart failure is more common by doing that. And often, this is a topic for a different day. But when you have a patient with a high number, you don't want to treat the number, right? Treat the patient. So if your patient has got pulmonary edema, yes, go ahead and treat pulmonary edema, and they've got really severe hypertension. If they've got aortic dissection and high blood pressure, yeah, you need to treat that. But if they walk into the clinic and their number is 200 over 120, and they are otherwise, not having shortness of breath or anything, then there is no rush to treat their blood pressure and bring it down to normal in the next half an hour, right? You can take your time. Give them what is happening is, there is an acute recognition of a chronic disease. It's not that they have an acute hypertension, right? That hypertension has been probably going on for months, maybe years, and no one has diagnosed it before. So you don't have to bring down the blood pressure immediately. You have to bring it down slowly. So it's more important that, you give them one drug. They are on nothing probably, or maybe they are on something, but they're not taking it. So add a blood pressure drug and try to see them again quickly, right? Bring them back the next day or the next week if it is possible. Which may or may not be possible, but really that's where the focus should be. The practice of trying to normalize the blood pressure because you just saw them, they are in front of you, is really not advisable. If they are sick with other things, right? Let's say they have got heart failure, they have got a vision problem, then they really need tertiary care. They need to be admitted. They need some monitoring. They need intravenous therapies, or you need to give them something and see what is happening over them. You can't just give you shouldn't just give sublingual nifedipine, see their blood pressure come down and say bye-bye. That is not really ideal care, as I'm sure you all know, but that's a really great question, and that should not be done anymore.
So we have another question from Dr. Shilpa Mulki, and she's speaking on research to individualize therapy. Like in the Africa Creole study, it says that the indapamide is great, and in an Indian study, it is advised to take as an evening dose for better outcomes. So what would your opinion be on individualized therapy?
Yeah, you should definitely individualize therapy, right? So in the patient with proteinuria, you probably want to start with ACE inhibitors or ARBs. But in many of your patients, and I think it's true across, culturally, you have to see, is salt intake an important aspect? I didn't go into lifestyle, but if salt is an important factor, your diuretics are going to work beautifully. So something like indapamide or chlorthalidone or hydrochlorothiazide, all of them will work beautifully if you think salt is an important factor. So yes, I think, again, cost is also an important factor. So, that may be another reason to use one over the other. If you have got a patient that you're worried about gout, then, maybe use a calcium channel blocker or an ACE inhibitor and not the indapamide. So that kind of thing is really is important. The evening drug, I'm not so sure. There is this research coming out of Spain and maybe in India as well, suggesting evening drugs are wonderful. If you take a drug in the evening or bedtime versus morning, the results are too good to be believed. There was a subsequently large trial called TIME, which was done in the UK. It was published in Lancet earlier this year, and it shows that it was way larger, about 15,000 patients, and it shows that it doesn't matter if you take in morning or night. There is no difference in outcomes. Now, again, I'm not saying night is worse, right? Morning or night, to me, morning or night doesn't matter. The important thing is that patients remember to take their pills, right? If you tell your patient, oh, take the amlodipine in the morning and take the indapamide at 6 o'clock and take the terazosin at 9 o'clock, they are probably going to forget to take some of those drugs. So I think that is more important, right? And if, I prefer to use long-acting drugs, and I tell patients take them all at once. That's fine. Whatever you remember, remember to take your pills is more important than the timing of pills. As far as I'm concerned, we need better research to show whether timing matters. Many of our patients have non-dipping nocturnal hypertension, but there is nothing to suggest that, indapamide is long-acting, amlodipine is long-acting. So whether you take it at night or morning, it's going to act over 24 hours. So I'm not quite persuaded by the chronotherapy proponents.
Thank you very much. And probably just a last one on the use of finerenone instead of spironolactone. What would your thoughts be?
Yeah. So I mentioned that, I put up this slide where I say spironolactone lacks end organ benefit data, right? So spironolactone reduces blood pressure, but no trial has shown that spironolactone reduces kidney failure. And that's because the trials have not been done with spironolactone. Whereas the finerenone manufacturer did do the finerenone trial, and Fidelio and Figaro, they do show that reduction in MACE, and they do show reduction in kidney failure. So these are effective drugs in patients with diabetic nephropathy. They are mineralocorticoid antagonists. The advantage over spironolactone is that this is a non-steroidal drug, so it doesn't have any of those side effects I talk about. Finerenone does not cause gynecomastia. It does not cause bleeding. It doesn't cause decreased libido. So that is that advantage that finerenone has. It causes hyperkalemia though. It causes less hyperkalemia than spironolactone, but it does cause hyperkalemia. So you have to be careful in the CKD patient. The biggest consideration is going to be cost, right? So it has been approved in Canada as well. We are still struggling to get coverage. So spironolactone is a few cents and finerenone is a few dollars. So that is the other thing to keep in mind. But yes, there is end organ data on finerenone for preventing kidney failure. Not for resistant hypertension, but I think those trials are also being done for resistant hypertension. It does lower blood pressure by about 2-3 millimeters of mercury, which is not insignificant.
Dr. Swapnil, this talk has been wonderful. Thank you so much for taking your time out once again. We understand you have a busy day ahead of you. I would like to hand over to Dr. Lloyd for a vote of thanks and signing the session off. Thank you very much.
Thank you very much, Swapnil, for this wonderful session, exhaustive, wide range of coverage and the approach to management, which is really evidence-based and a lot of information. Especially, I think that Flozin use is actually a great suggestion for heart failure, CKD, and diabetes. I think. Thank you very, very much.
Yeah, always welcome. Thanks again for the invite. Would love to chat again.